First, I'd like to thank everybody for coming. We're going to try to cover a few subjects. That's kind of the reason I jumped up here real quick, because everybody's asking me 50 different questions, and I kind of like the whole group to kind of jump in and understand what we're talking about. We're going to be talking about pain medication. It's called Amyloxine. Let me get my pen. And let me count to 5, and I'll get this organized. We did this last time I did a seminar. I kept turning this thing, squeak, squeak, squeak. And I got this mouse running around in the video now. Amyloxine. And it's got a little hydrochloric hit on the back end here. Originally, this medication was developed for HIV patients. Back about, I have to say it's almost 13 years ago, I was called in on a project. At that time I was working in diving physiology. I'm one of 5 experts in the world that actually is a pressure doctor when it comes to hyperbaric chambers. It was my field of specialization. Majority of our Air Force personnel that we have that work in hyperbaric medicine, oxygen therapy, they're kind of basically vacuum physicians. And they read our books on how to apply pressure, how to apply high oxygen to patients. When HIV came down the pike, oxygen therapies were looked at because they were considered one of the least offensive ways to go into an HIV patient. HIV patients in general, it's difficult to use any type of medication on these patients because they're so reactive to patients. What's normal to them is actually, what is normal to us is actually deadly to them. Even down to just the dust mites that are in the air right now. Our immune system fights it off, but their immune system actually shuts down. We quickly found out that the enemy actually in HIV was actually the medication, AZT. AZT had to be one of the most perfect medications on this planet to create patients. It worked beautiful back about 30 years ago as a medication for thymus cancer. Worked great. It shut the thymus down, shut down the mutation of the cancer cells. But the problem was it had 28 associated side effects that you died from over 30 years ago. Then they dropped it into our HIV patients, and the same thing happened there too, is you had 28 associated reasons that you died from HIV. Well, they were all stuck back to AZT. There's some very hard disciplines out there that it's still very difficult for them to understand that. But in the view of working with these medications back about 12 years ago, we were using the interleukins, we were using hormone interrupters. We were doing every type of medication you could think of that just now the cancer industry is starting to look at and do hormone therapy in our cancer patients. And they're linking it with their great Toxol. Toxol was a poison the day it was made 30 years ago. And up till November of '99, it had never been approved by the FDA. In November of 1999, it was brought online as an orphan drug by the FDA. The problem is most of the public interpret this that it was okayed by the government to be used. An orphan drug, by definition, is a drug that is in use, but we have no idea what it's good for. But it's been around for so long, we need a classification on it. And that's the only thing it met here. And again, it was okayed under the orphan law for use in HIV patients, not cancer patients. It's because it was the least offensive way of actually getting it on the market because they're already using it in terminal patients that they consider with HIV. And in the same process, a lot of my patients have been pulled in that Toxol is the way to go. Toxol kills tissue. It's that simple. Kills healthy cell tissue, kills cancer tissue. Radiation does the same thing too. The only thing they don't tell my cancer patients in Toxol uses, it also mutates tissue also. It's interesting to watch these side effects in the patients because I get to observe some very interesting patients. My patients usually come in their 3rd, 4th stage cancer. What most people don't realize about my background is the HIV patients we worked on also had cancer, arthritis, Parkinson's disease, Alzheimer's, multiple sclerosis. These patients had all these as secondary problems to the main disease. And what we had to learn how to do was to eliminate these diseases so we could stay focused back on the main project, HIV. So it's very accustomed working with these patients to have labs come in and see increased circulation in a patient, arthritis symptoms were gone, cancer tumors were reducing in size, and yet we put no focus on this because our focus was back on HIV. We were after the number one animal. So we made minute changes. We're able to put magic chemical mixes into patients, see the results within 3 or 4 days because we were yanking labs every 3 to 4 hours on these patients. That's how fast we could adjust. And at the same time, we were getting a lot of feedback from different patients coming in that were under other treatment programs. So we were able to accelerate treatment and research at a very accelerated rate. When we went back to looking at the HIV patients, the most interesting thing here was the numbers that we were dealing with. For some reason, all the importance went on, we've got to find a cure for HIV. Notice I didn't say fix or treatment. I said we had to find a cure. The problem is with that term, last year, less than 14,000 people died from HIV here in the United States. That's how important this disease is. 14,000. I even got lost in the numbers too. Last year, a little over 250,000 people died from cancer. 2 million were diagnosed with cancer last year. Cardiovascular was a little over 222,000 died last year. Diagnosis was 1.5 million people this year. Now, that's not to mention the other diseases. What most people don't realize about Alzheimer's patients, approximately 200,000 patients a year are diagnosed with Alzheimer's disease. Now, where do you think my focus should be if I was getting improvements here all the way? But you see, that's how research changed. All the research money went for this guy up here, HIV. All these guys got sidetracked. But I'd like to show you where the research came from for the last 10 years in each one of these. Cancer patients, National Cancer Society, all the big guns, the billions of dollars in research came to 2 conclusions. One, if you're diagnosed with cancer, see another doctor, get another diagnosis. That was their number 1 suggestion. Their number 2 suggestion was, what a doctor's doing on the East Coast, a doctor on the West Coast usually doesn't know about. Research your own disease. I would like to know where the billions of dollars that went in cancer research. The problem I have with that is their billions of dollars of research came back to Toxol and interleukin mixtures, which we gave up on over 12 years ago because we saw the same side effects they're seeing right now. It's too devastating in the patients. So you tell me who's behind the curve here. The interesting thing about HIV is right now, you know what the newest research is on HIV? Quit taking the medicine. Your immune system will fight the disease, and 90% of the patients it will control the viral load. The pharmaceutical companies jumped on this immediately and said, well, you need to be on our magic cocktail mix for at least a year, and then you come off of it, and your immune system will kick in. The only thing that's been suppressing the immune system is AZT. Any medical journal you pick up under GP, under AZT, if your white cell count drops to 800, you come up positive with HIV, you tell your patient to take AZT. And then it has a real small caption in small print that you can just barely read. Inform your patient that their immune system will be shut down for the next 8 months when they take one pill. Remember, this was used for thyroid cancer. Shut your thyroid system off, you just shut off the top of your immune system for 8 months. And it takes 8 months just to recover from one pill before it comes back online for your protection. And it tells them notify the patients. And we're victims in this. And that's exactly what I come back to. They came out with what was known as a PCR test in HIV. What they didn't tell everybody is, you come up positive on this, you have HIV, right? What they didn't tell everybody is there's over 200 other reasons why you can come up with a positive on this. Could be a history of chicken pox, history of malnutrition. They will all trigger the antigen for this guy to come up positive. This test is what the entire industry is based on. So what they did is they created a bunch of false PCR tests. When they tried to use the PCR test in the O.J. Simpson's trial, they couldn't even bring the developer on the stand because he couldn't vouch for the accuracy of this testing. They had to throw all that information out of court. That's how accurate this test is. But I've always asked the question, out of these 14,000 deaths, I wonder how many were created because of a false positive. Because the moment I know they were put on AZT, they were brought into the death range at this point. Because it's the side effects of AZT that you die from. Nobody has ever died from HIV. Nobody has ever died from cancer. And that is the big shock. They've died from Toxol, they've died from radiation, but usually what happens here is you set off a chain of events in this type of patient. The death certificate will not read death due to cancer. It will read death due to respiratory failure, infection. The big killer here when it comes to most cancer patients is colds, flus, pneumonia, or an atrophic infection that you might have picked up while you were at the hospital. When you came to the hospital, we gave you a different type of infection to take home. So as my cancer patients, I tell them what you protect from: colds, flus, pneumonia. Cancer won't kill you. That's a cold fact. Cardiovascular, it's a little bit different, okay? And cardiovascular patients right now, their recommendations, it's incredible. Would you rather have the recommendations or the apologies? Salt, good or bad for you? No, y'all know this information. What has your doctors told you about salt? Why?
Gives you hypertension, high blood pressure.
Interesting. Now I have to, excuse me, I have fun with you to a certain degree on this. It's because I inform my patients so they do know. The reason my medication works so well is not due to the mechanics of the medication, it's also due to the mechanics of how it's applied and what the patient learns at the same time. That's the reason I have every one of my patients listen to one of my videos, because there's a lot of information in here. 2, my cancer cardiovascular patients do not have time for me to lie to them. They do not have time for me to say please and thank you. And I'll show you exactly what the problem is. The problem with most physicians when it comes to explaining something to you, we're going to talk about salt in a minute, is this number right here. 7.5 minutes. That's the problem. That's the average across the United States that a physician spends with their patient. So as a cancer patient, you come in, I see you for 7.5 minutes. Getting some labs, you come back for the next 7.5 minutes, I tell you you need chemo. And what have you just become? 15 minutes is just what you just based your entire life on. And that's what you are. You're on the clock. And that's the problem with most physicians. And it's because of the demand. They have that many patients to see that they cannot really sit down and give you the more simple mechanics of some of the stuff of why it works and why it doesn't work in you. I see one of my average patients, I spend about an hour on the phone with them. One is basically just to introduce myself. I'm assessing how much patient I have to start with in the first place. And the other one is if you're not in an intensive care ward and if we have to use an air ambulance to get you there. And in between this, I'm trying to furnish you a little bit extra information. You spend about an hour to an hour and a half listening to one of my videos, listening to me tell you about everything under the sun and chemistry and everything else, and how lucky I am at some things. But when you come to clinic, you spend about another hour and a half. I spend an hour and a half to 2 hours because I like to do a real thorough history on my patient. And it's mainly because I don't have you going up and down the road to come back and forth. Next day I see you for about 30 minutes. When you figure all this up by this equation up here, 7.5 minutes, you can see that I'm seeing you from anywhere from, it'd take 10 to 15 visits to be able to get that much information into you with your own private physician. Because I find out in my patients, like I said, cancer does not kill you. Infections will kill you. And I'm the first person to tell your family thank you because they do care about you enough. But also your family kills you too. And it's out of love that they do this. It's because they're lost in the same machine you are. They're lost in the same disease you are. And they're looking for answers too. I always ask the question, you spend 4 years in college, well usually 3, and you spend another 4 years in medical school, and then you do a residency in cancer, specialization of cancer for 3 years. What is your true specialization right here? Any diagnosis you come down with always comes back to chemo and radiation. So you spent 3 years to learn how to classify cancer, but it always comes back to the same treatment regimen. If I take chemo and radiation away from you, what is your specialty? If those are the only 2 tools you have to work with, you have no specialization. And that's where the patients get lost. They come in, they get into this first 7.5 minutes. It's already pretty obvious if we're dealing with cancer or not at this point. We'll send you down the hall, get a couple film shots. We'll come back with the assessment the 7.5 minutes later. We said, well, we need to get you in a chemo radiation regimen. It doesn't matter if you're a cardiovascular patient on top of this. We just got to do some modifications. Because see, other diseases come with this. Diabetes comes with it too. And odds are you're probably on 2 or 3 other medications for a few other things that might be wrong with you. And so in 15 minutes, we've just dictated what your life is going to be. If you're going to live or die. Excuse me if I don't make it any easier than that. 15 minutes is what you base your entire life on at this point in time. And it comes right back to chemo and radiation again. The problem is in the last 30 years, they have not really worked for another option here. All they know how to do here is destroy tissue. And it doesn't matter if it's healthy tissue or if it's cancer tissue. How do you starve cancer tissue without starving healthy tissue? So do diets work? No. Because you're starving the mechanism that actually repairs stuff here. You cannot affect one without affecting the other. So it moves into a very interesting equation when you're dealing with this. The other problem you have too, and you have to excuse, I'm hitting real fast and quick on this, is the insurance companies. And you have to know how these guys work. It's not the personnel involved, but it's the arrangement between them and the hospitals and the way they're doing diagnostics. And it's just the way the mechanisms. We have these things called CPT codes. It's the way we code insurance to be able to pay for it. And believe me, insurance has done a lot to help the health of America. I'm not extremely negative about it, but you have to know where the motivators are here to a certain degree. As a cancer specialist, if I cannot get a name on your cancer, I have not made the main amount of money on the policy at this point. The moment I can diagnose it as some form of carcinoma, I get a lump sum of between $2,500 to $2,800. That's what I get paid, the moment I can put a name on it. And this is the same way in some other diagnostics too. That is the lump sum I get paid. If you come see me the next day, I get $150 for an office visit. Now, do you think I want to talk to you about your bunions or do I want to diagnose you with cancer? as a physician. And believe me, physicians aren't cold. When I worked here stateside, it cost me over $21,000 a month just to keep my office open. It took me 3 weeks just to pay the bills. And then I was lucky on the 4th week out of the month, if I had a few patients, that's where I made my money. And believe me, I don't work for private research anymore. An average physician in the United States right now, if you're male, clears approximately $54,000 a year. If you're a woman, you make approximately $48,000. That's what the average physician clears after all the bills are taken out. Doctors aren't rich, especially if you stay in that bracket, okay? But if you specialize in this bracket right here, so it makes more sense for me to be in diagnostics, okay? So as long as I'm diagnostic, I'm getting this money on them. This way I can own my own golf cart. If I'm working at this level right here, I can't play golf because I'm too busy working paying the bills. And that's kind of the way it works in our specialization right now. And it's just the way the system's evolved up here. And the definition right now is, the problem we have in medicine is the federal government, the state government dictates the way medicine will be used. They look at it as if it's a cold, hard science. A plus B equals C. When did medicine ever become math? Every one of you is a different chemistry unit out there. Every one of you have been exposed to different things on this planet. And that's what I try to make everybody aware of. You do not all respond the same to medication. I haven't seen that one come across the pike. It's incredible some of the medications we have right now. They'll say, take this for your asthma and you will be okay. And then way down here at the bottom, they got at the bottom says, oh, if you have nosebleeds, you cough, and you throw up half your right lung, that's to be expected side effects, okay? So all of a sudden it's okay to take, okay? Because the guy that was saying this said it so fast that you didn't hear all this. So a physician will apply medication, and if they're good, they will observe. And then they regulate your medication to the condition. The problem is with the type of patients I work with is disease does not know these rules. And sometimes disease creates the rules. It creates the game plan that you have to work with. And then somewhere in the middle of all this, a couple of other doctors get in the game and they mess the chemistry up in the patient. And I get what's left of that puzzle. There's a good reason they come to see me. It's because I'm very good at solving puzzles. And the interesting thing here, it's usually the simplest fix is usually the best medicine. Because again, we've gotten into a complicated world that we want a very complicated fix for a very simple form of a disease. What happens is my patients get lost in the confusion. Don't pay these bills, okay? Solved, okay? When I get through with one of my patients in general, we put a very good medication in, depending on if we're working against cancer, if we're working against cardiovascular, and we do modifications to the medication depending on what we're after. It's the information the patient carries back at that point in time is what helps them succeed. Every one of my patients are incredible. They're overachievers. They do not know the word no. They're the most motivated people on this planet I've ever met. Even in death, they're on the hustle. They're survivors. And that is one of the keys. That type of survivor puts off some incredible chemistry inside their bodies. You come in the door and says, oh, doc, I'm going to die in 2 weeks. And it's incredible. They look at their watch. And I said, why? Well, we just flew in from the mail. 3 doctors said I've got 2 weeks to live. And I went, what time? You know, Tuesday at what, 2:30? And they said, well, no, they didn't say it that precise. And I go, well, why are you looking at your watch? To the second. But the incredible thing is the moment you remove what we call traditional medicine stateside out of there, the clock no longer applies. They can't tell you when you're going to die. Chemo is incredible. You take chemo, you live 2 years. This is what it says in the books. You don't take chemo, you live 2 years. Okay? And if the chemo works or the chemo doesn't work and you live past 5 years, that is the average. That's the way they do the math on this one. Whether it worked or didn't work and you live 5 years. The success rate on this in the cancer industry is based on this number right here, 5 years, whether you took the chemo or not. But usually the average chemo patient does good to live beyond 2 years. This is a big number, okay? Big number. The success rate on this is 9%. Their number's not mine. That means you survived the chemo. You didn't survive the cancer. But if you dig back into their information database, and I'm talking about 13, 14 layers underneath here, and you look at the success rate without chemo, this number moves up a little bit. It moves up to 54% success rate. Which one do you prefer? That's without chemo. The body is very resilient at healing if you just furnish it a little bit of what it needs. But the moment you stick a poison apple in it, what do you expect it to do? Expect it to fight. And it fights tremendously. Sodium chloride. Good for you or bad for you again? Hey, doctors told you this. I didn't. No, I just said doctors. I didn't tell you. I'm a surgeon. That's a big difference. Doctors work for me. They lay on the table. They're my patient. Okay? That's the way it works with me. And it took me almost 14 years to earn that just in residencies alone, not the experience behind me. I've done 4 years general surgery, 4 years emergency surgery. I just came off a 3-year residency, which they said I was too old to do, in plastic and reconstructive surgery. And last year I completed my boards for homeopath up here in the States. So I've been busy because I deal with homeopaths to a certain degree. A naturopathic medicine, and I figured I should have a piece of paper here to be able so I could speak as an authority. So I took their board exam too. So I'm board certified in the United States in that too. I was having an interesting conversation with a friend of mine the other day about credentials. Medicine doesn't kill people, hospitals doesn't kill people, credentials kill people. And that's the problem here, because the higher the credentials, the more faith you put in the person. You think their medicine is better. The last time I checked, Toxol used here and Toxol used by the most primitive hospital in Brazil is still Toxol. And it still comes with the same little sheet of paper, how many injections you're supposed to do on the patient. But which one is the best Toxol? The one at the Brazilian Jungle Clinic or the one at the Mayo Institute? Oh, the Mayo Institute, they got more credentials. Well, that's the reason they come see me, the doctors, the staff, not some of the patients, but that is it. As it is right now, I have treated 28 physicians from 3 of the major cancer centers in the United States. They're all back working. So I got to be doing something right. Somewhere's in their education, please don't understand, I was never a liberal science type person any place. My master's is from Rice University in chemistry. I know my chemistry pretty well. Luckily, I was smart enough to get through that one. Sodium chloride. Anytime you have a cell, anytime nutrition goes across that cell membrane or comes out of that cell membrane, it has sodium on the front end. That's the way it works across your cell. It's no more complicated than that. Do any of y'all have any idea what chloride is used for in your body? Digestion. Yeah, well, you've heard this. Okay? It's one of the few ways we regenerate the acid in our stomach for digestion. So what happens if I take sodium chloride out of your diet? Well, it causes lousy cell transfer. I gave you lousy digestion. So what happens next? You get sick. That's what salt restriction does. The American Heart Association for years, almost 30 years, advocated the reduction of salt in your diet. With the same attributions that you just told me. Last year, they came out and apologized and said, we're wrong. That's all they said, we're wrong. That was the entire length of their statement. Potassium and calcium is what causes the problems in you. Now let me ask you a question. For the last 30 years, we already knew this as physicians. In cardiovascular emergency, what's the first thing we do when you come into the emergency room? We put a saline line in you, sodium chloride, to help transfer chemicals in your body faster. And to keep you alive, to regulate your heart, we inject potassium and calcium. And all they said after all this lousy digestion and cell transfer that they created in our patients over the last 30 years was, sorry about that. And who do you sue? And that's what's incredible about that. That's how information is passed out, but the liability of that information is what we have to live with. So we get the end results. We get the back end on this. So 30 years of this guy being restricting your diet, what I end up with is I end up with a patient that has a very interesting vein. Well, see, from day one, when you were born, it kind of looked like this. Might have been a little straighter, okay? But as time went by, these clumps started developing. But the interesting thing is it also started creating linings with inside these veins. We'll start off with an artery here and we'll move forward a little bit. And then we'll move out to just a minute vein. And just to save some time, we'll move all the way out into a small capillary like we have inside the optic nerve. You can count on one thing. If these clumps and everything exist up here, they also exist all the way down to the smallest capillary. And somewhere around here is where the cell gets the circulation and nutrition off this guy. The average woman at the age of 21, if they took in 200 milligrams of calcium, will absorb approximately 22% of that. Okay? 200 milligrams. At the age of 50, she takes in the same amount. She absorbs less than 2% of that. Because you plugged up. And, well, as I said, between 21 and 50, all this stuff developed. So the way the industry interprets this is, well, we'll just get her to take more calcium. You'll take 2,000 milligrams of calcium. You've heard that one, haven't you? Huh? Well, you see, the problem is you can take 2,000, but your absorption rate will still only be 2% of the original 200. And so what you end up doing here is you end up working your liver a little bit harder, working your kidneys a little bit harder to filter out all this excess calcium. But your bone density doesn't pick up. People ask me about arthritis, how this relates in arthritis. Arthritis, just like any other type of disease or condition in our body, always starts off for number one thing. Restricted circulation to that area means lack of oxygen. Lack of oxygen to the cell tissue makes it go dysfunctional. It doesn't function properly. You make enough cells go dysfunctional around a joint, it starts shutting down nerve tissue. Nerves are the signalers here. They send the signal back to the body, says, send more blood. Those little guys start getting plugged up, shortened down because they're getting a lack of that. Arthritis gets into the game. Cancer gets into the game. Cancer always seeks the lowest oxygen content of the body. And that's what happens in these areas. It's how disease gets in the way. If we were 21 years old and a pretty healthy body, we could fight all this off all the time. But see, the problem is the clock's working against you. It's plugging up. And that's exactly what's happening. It plugs up. So absorption gets slowed down in those areas. Now we start seeing arthritis getting in the game. If it's in your lung tissue, you'll see how more evasive diseases are. Isn't it interesting how flu becomes more and more serious every year when you catch it? It's because of the plugging up mechanism. They have what's called chelation therapy. Chelation therapy was designed to knock all this stuff out so you could get absorption back into your lung and back into your body. The problem is with chelation is it will strip out the potassium and the calcium, but you have what's called a fibroid material. It's kind of like our body's form of a stents of holding the veins up. And it looks like a fishnet. And then it plugs up with all this stuff to eventually, in some of the patients, the older you get, you end up having a full blockage where no circulation gets down the main guy, much less all of these. And in the process of all this happening is chelation therapy. It will strip out the potassium and calcium. It will improve the circulation to a certain degree, but it leaves the fibroid in place. So it filters for 2 years, plugs up again, and you go back into chelation. The problem with chelation therapy is it strips this potassium and calcium out so fast that it strips the vitamins and minerals out of you so fast that in the morning you're doing chelation, in the afternoon you're doing vitamin and mineral IVs to catch up on what it ripped out of your body. You're trying to play catch up. And usually what happens here is on the back end is you don't feel good from this part, but you feel good from the vitamin therapy at the bottom of the day. Because your body don't have to work as hard to absorb it. But along comes 2 years, these guys plug up again, and first thing out of their mouth is, well, you got to come in for more chelation. The interesting thing is if you do the math on this one, it usually takes about 40 treatments. They usually run about $150, $125, $200. I've seen them as high as $2,000 a piece. And before it's all over with, you spend approximately $15,000 to $18,000. So you can come back in 2 years and do it again. But the problem is stripping these vitamins out and everything at the same time it's detrimental to your body. It takes it almost 2 years to catch up on the vitamin and mineral lossage at this point in time. The next one is here on chelation therapy is the approval under the FDA under chelation. Most of the doctors that do chelation therapy, the first thing they do is say, shh, don't tell no one we're doing this. It's not approved by the FDA. They pull you in by the paranoia here. Well, I'm getting something done, it's good for me, but I'm doing it for you for a special price. But don't tell no one. Believe me, they're out there. I deal with these guys every day. They've told my patient every story, including them. I think one of them actually came from Oz, if you want to know the truth. I hear it all. I see it all. And in the process of doing this, the FDA's official ruling on chelation therapy is nobody's ever filled out the paper to do the studies. So there's no reason to hide. But they use the paranoia to keep the patient closed in. It's incredible that you have physicians that do this, but they do. And I try to make my patients available about this, understand why this treatment doesn't work. It has a temporary result. I also tell my patients when it comes back to vitamin therapy, vitamins are the wrong way to catch up when it comes to cancer or cardiovascular. Vitamins and minerals, true, are the fix. They are the tissue repairers. There's no question about that. But what you take orally takes a little over 2 years to be absorbed into your system before we pick it up in tissue samples later on down the road. Vitamin E is probably the slowest here. Exception to the rule are B's and C compounds. They go directly into the blood. But most cancer patients I have and cardiovascular patients, do you have 2 years to wait? Because the disease is progressing much faster than that. You do not have the 2 years. The vitamins and minerals are the preventer. All I got to do is I've got to figure out a way to buy 2 years to get that 2 years, to get that to kick in, to be the preventer, so you don't have to come back and see me. So I've got to jump the gun. So undoubtedly, unless you're going in with something IV at this point in time to build the system and structure it back up, you're wasting your time. It's the reason the diets don't work here. It's the reason vitamin therapy doesn't work here. Most of the people that wrote these books are not here anymore. Try to track one or two of them down. Vitamin C saved my life. Cured my breast cancer. Well, you know, I asked the same question like everybody else. I would really like to talk to that author. But by the time you catch up with it, you find out that she's long gone. Because it didn't totally fix it. Nothing will fix cancer. So I don't work for cure, I work for control. My belief is from day one we're born with cancer. It's just cancer goes haywire in our lives. Those cells were in us when we were born. It's not a DNA structure. DNA structure coding, I don't think I'm going to get into it, but that's a joke, okay? 2% of all related diseases we fight out there right now can actually be proven with DNA coding. So let's go back to the 98% that are not affected by DNA coding. So don't waste your time waiting for DNA codes to catch up here, or DNA coded medicine. They're so far behind on that, it's unbelievable. They'd have you believe otherwise, but it's not true. In this type of medication, we had to find a way not to hurt these healthy cells down here, but we had to find a way to lock up cancer cells. Cancer cells in general are the true vampires. They take everything in, they give nothing back. Exception to the rule is 4 forms of rare cancer cells. We very rarely ever see this. They're like in our top 3% cases. But this guy will trap everything that comes into it. That's what it's notorious for. Healthy cells, on the other hand, if they're sitting out here, will take it in, push it out. But the interesting thing is about cancer cells, let's do like a lung cancer type thing here, is they put out these little feelers and they attach to the cells. Not just 1 or 2, but thousands of them come out. And they're just like a straw hooked into a healthy cell. So when they're absorbing nutrition, it goes through a healthy cell into a cancer cell. Cancer cells have what's called an abnormal nuclei. It can have one or it can be multinuclei, or what we call combo nuclei. That's where it went dysfunctional. You ever asked your question why your body doesn't reject this cell right here? If it's so devastating? Can't. It's the same DNA code as the rest of your cells. It's part of you. So it didn't abnormally infect you. So it's normal for it to be there. So the body has no reason to attack it. So you can boost your immune system as much as you want, it still does not know who the target is. So immune boosting, you've heard that term too here. Let's boost your immune system to fight cancer. Why? If you're going to boost your immune system to fight colds, I can understand that. But how's it going to fight something that hasn't been coded as the bad guy in the first place? I don't care if this is just one little spot or if your entire colon is hanging out with cancer. Your body still does not know it's the enemy. Immune system never kicks in. What happens with our medication is, with Amyloxine, is healthy cells, their nuclei are very sets. So they can take the medication in, pass it out. See, it doesn't affect it. See, I'm not changing chemistry in your body. I'm just getting the cell to do something very unique and getting it to transfer an agent across it that doesn't affect it. But the neat thing is why this guy is coming into the healthy cells, the cancer cells over here are feeding on it. Remember what I told you? They can take in, but they can't get rid of. And that's their weakness. So the neat thing here is, let's feed them something he can't digest. Basically, we constipate him. Okay? I mean, it's really difficult here. I can use a really long 26-syllable scientific word, but no, we constipate him. And that's exactly what we're after. Now I'm going to step you up onto something they don't want you to know about, okay? And please, a few of y'all have heard this before, but kind of let the other guys kind of play with it too so they learn. I'm going to draw a picture of a liver here. I'm getting better. I can almost draw one. Okay? And it has to do with our system. I want you to know where some of these words come from that people bet their lives on. And it has the same thing to do with my cardiovascular patients as it has to do with my cancer patients. The most interesting thing about amoxicillin is the first thing it does when it goes into the body is it dilates these guys. Mild dilation to increase circulation. What most people don't understand is when this layer forms, when it forms over tissue, the tissue underneath it becomes abnormal because it can't absorb. So it's coded to be replaced. It's the same as this cancer cell down here. It absorbs. See, the chemistry set went dysfunctional. Most cell tissue in our body replicates about every 10 minutes in our body. In general, bone tissue runs between 12 and 14 days. The slowest thing in our body is the thymus gland. 27 days. So I want you to know how timers work here. Unless you're taking something that goes 27 days, you're not going to get it every cell in the body. Especially when it's metastasized. We learned this from HIV. This is the reason this guy kept getting stored in the thymus. You could throw the meanest mixes on the planet at him. But unless you went beyond 27 days, you hadn't gotten exposed to every cell in the body. Our medication crosses the blood-brain barrier. One of the few that does on this planet. So neural tumors are fair game here for us too. Again, it was designed to go after HIV. I had to design a way to go across the blood-brain barrier. Can't remember what I designed him for. I designed him to get at every cell in your body. The most interesting thing they don't tell you about HIV and cells is they would have you picture this little, if we drew this on the side and that, okay, this room is a cell, okay? HIV would probably be about that big. That's the reason you can't see them until you get around about 91,000 under an electron microscope. I can speak with a little bit of expertise. I'm one of the few people on this planet that lives in a house that has 2 electron microscopes. Have both the transmitting and scanning. And I own them, and the government doesn't. I take my own pictures and I show people. There's a lot of truth in pictures. Okay. So there's very few doctors want to oppose me for the simple fact is, I got a picture, show me yours. They got to stand for 2 weeks just to get access to a scanning electron microscope. I don't. I got a question, I get it answered that night usually. 91,000 is where you actually see this guy. Do y'all know that the CDC had to wait 2 years to get the funding for an electron microscope before they could go hunting for HIV? All the rest of the institutes were out there looking, but our own government that regulates our own medications and disease in the United States had to wait 2 years to get $500,000 in funding to buy an electron microscope before they could do the hunt. But they were making the rules. Well, anyway, I'm not going to get into the politics of who stole what from who, okay? Is when they have you visualize this guy, they would have you see this one little dot attacking the cell, okay? What they don't tell you is there's thousands of these attacking one cell at one time. And the reason I bring this up is because I'd like you to understand how fast eugenics really works. There's so many of these guys attaching and exchanging what they call panages. You have 2 little panages run in, they bite, they come back. All of them are doing it, but they don't all go back to the same one. They all go back to different dots. They go to every which one is available that's hooked onto the cell. So you could have a primitive virus moving up to an advanced virus. You can have an advanced virus moving back to a primitive virus. This is how fast this guy. I'm just letting you know who my true enemy was here. This replication rate was 127 to the 24th over 10. Interesting number, isn't it? I never had very much use for scientific notation. That's 127 with like 2,400 zeros behind it. Well, it's like 100 trillion, billion, million. Whoever knows that, please tell me, because I never could count that high. That's how fast this guy replicates every 24 hours. New virus. That's how many new viruses you have every hour with this guy. Every 24 hours. Now you think a vaccine can be built that can mutate that fast to keep up with him? That's the reason a vaccine will never be designed for him. His replication rate is that fast. Now you throw cancer into this, you throw diabetes into this, you got a pretty sick person. That's where I step in at that point in time. And they go, Dr. Truitt, what do you think? And first thing out of my mouth is usually, I think you're going to die. All I'm going to try to do is I'm going to try to stretch it out a little bit before it happens. And that's what we're into. We're into life. But you've got to know some of the mechanisms to extend that life. And it doesn't come out of just one bottle all the time. It also comes out of your brain what makes sense. You see why diets don't work now. You see why basically vitamin therapy can't catch up. And we're going to step on that right here. Interesting thing about our stomach. I'm going to draw it down here. This guy was in a car wreck, so we had to move his stomach down, okay? All right. Is most of the herbs that you take in general, when they hit the stomach, are converted to either calories or protein. It means they became a food source. They weren't a chemical source. There's always exceptions to the rules. In general, most pharmaceuticals that we take have been isolated so they get past the digestive process and eventually is absorbed somewhere in the intestines. And we get the chemical use in it. You have to also remember when it comes to alternative health that most herb technology was developed around like 1600s, 1700s, 1800s. Why did it work so effectively then but not as effectively now? It had to do with your lifespan. I mean, around the age of 21, you're a pretty clean puppy, okay? So you can absorb it. Now we're dealing with an age span where our age span back at this point in time was probably around maybe about 35. Because it's a hard time to live in those times. And usually the doctrine came up the line with herbal technology with that. Will it work? This will work. You know, if I hear another herbal treatment, I think I'm going to go crazy. But some of them do work. But again, you have to think of the age of the person, the condition of the vein on absorption. I mean, it's just one thing doesn't fix it. The thing here is know your different tools. That's the key. If you get the tools in the right order, they work. So what happens is most of the stuff comes in here is converted to protein, calories. You got the food value out of it. You really didn't get anything out of it. So until you clean this guy, in general, you're almost wasting your time. But that is the goal of the medication. In the first week and a half of the medications, it's designed to chelate this. And the way it doesn't pull the potassium, calcium out. It codes the nave layers of the veins. There's like 3 of them here. If you're dealing with a vein out here, they're like 3 layers. If you get close to the heart, there's like 5 layers. And they're different cell structure. The stuff around the heart's real strong. But that inner layer is always coded to be replaced. So what happens is the medication codes that to replace, and in the process, all this sloughs off, leaving a nice, clean vein. This happens over like a 30-day period. It's done real slow, real easy. You don't even know what's going on inside you. The 2 chief complaints I get from most of my patients about 2 weeks into the oral regimen is, Doctor, I'm tired, and 2, I'm sore. And Otis, why are you sore? Because you're doing too much, and you're still eating the same way. You got to feed the engine. It's just that simple. You're going to start doing more. It's the reason you're tired. We're creatures of habit. We know exactly what we take in. But when we put our demand up, you've got to increase. And it's just these simple changes. I tell you, eat. That's real simple. That's all I do is tell you eat. They go, what should I eat? Oh. I'm not going to write that diet book, so everybody wake up to that fact right now. You eat what you were fed at the age of around 12 or 13, 14 years old. What your mom would have fed you, what your grandmother would have fed you. Get the microwave stuff out of your lives. Mom and grandma would not feed you anything bad. Meat, potatoes, very balanced diet. And you do know when too much is too much. Candy does not count here, okay? I know you guys, 12, 13, 14, you can go after candy too, okay? But that's what you eat, and that's what you base your diet on, because that's when your cells went through their first major change prior to puberty. And that was the programming that was put into them to make them respond the best at. So you go back and you look for that guidelines. And believe me, what one diet is for one person is not for the other person because you both did not have the same grandmother. Believe me. I mean, I've got people that can take olive oil, they lose weight. Italians, I love them, but Italians eat olive oil, they gain weight. If you're Hindu or Indian in nature, your entire diet is based on sugar. It's incredible what their sugar intake is. Do y'all remember back, and I don't know, now I'm going to stretch back, I'm not that old, okay? You remember back when it used to be a nickel for a cup of milk for South Africa? The Red Cross? Send your nickel so we can do it. I mean, we all sent it in school. Do you know why that program was stopped? And it was stopped cold. Because they killed over 500,000 South African kids. Because they're not milk-based, they're not lactose-based, they're starch-based. So they went over and gave 500,000 kids diarrhea, they couldn't stop, and it killed them. Now you tell me your diet's the same as the guy sitting beside you. No, some grandmas make better biscuits, is the way I look at it. My grandma made the best biscuits, but she also taught me how to cook. Says you will not ever have to depend on marrying a woman to feed you. You'll know how to cook everything on this planet. So I had a really good grandma. I don't know, my wife's glomki kind of is better than I can make. She's pretty good. The liver. This is the one you got to really nail into. We've got a vein that runs into the vein, into the top of the liver. It's called the venous cavus, called a VC. And then down at the bottom, you have the hepatic artery comes out of this. And then you have what's called the biliary tree within the liver. It's like, you need to take notes. We got a test after this. Okay? And you better have the spelling right, because I won't. Okay? The interesting thing is what happens here in the biliary tree. We talk about the liver function. It's incredible what we know about the liver and what we don't tell people about the liver. This has got to be the main chemistry set in the entire body. And we hear about the terms bile into the liver, liver does filtrations, and I mean, it's a ton of lore that goes with this guy. Chemistry is going to get about this advanced, but I'm going to keep it very simple because the main thing is here is you get a general understanding of what happens here with this guy. We do not call it bile, one. It's called mevalonic acid. And it's basically what the body is sloughing off. Even if you have residual cancer cells in your body, around about stage 2, stage B, the body is dumping cancer cells back into your body because it's just trying to get rid of them. Doesn't mean it's spread. It's just an excess of cell tissue. And the liver is the first catcher on this one. And at this point in time, usually if I find cancer in you somewhere else in the body, the next thing out of my mouth is, well, we need to do a biopsy on your liver to see if it has cancer also. Remember I told you there's cancer cells that are being filtered to get rid of. I didn't say you had liver cancer. But guess what happens when I stick a syringe in there? I just gave you cancer because I caused it to hemorrhage and the cells could move up a layer. That's the reason I caution my patients when it comes to always assume there are liver cancer cells in the liver. Stay away from the biopsy because you just bought yourself maybe another 5 years of life because you didn't cause it to spread. And this is usually the way it's spread in most of my patients. Well, we need to do a biopsy on your liver. No, it's just trying to filter them out and get rid of them. Body's doing something here it's never had to do before. The next step is from mevalonic acid, it goes to a compound called IPP and DPP. This is just an iso and di form of pyrophosphate acid. Oh, you really like these terms, don't you? I can just tell you, give me more. The interesting thing is at pyrophosphate acid, it's digested, or it's converted one more time into an animal called isoprene. And this is where it starts getting interesting. a group of physicians went after isoprene, thinking it was the fix for cancer. And you're going to understand why they went for isoprene. So what they did is they mixed ozone with it at that point in time, O3. And interesting chemical reaction happened. They mixed it with O3 here. The next thing it did is these two guys put together made plastic. The biggest problem here is you couldn't inject it into the patient. You couldn't get it out of the syringe. But this was the fix for cancer. So if they'd just done their chemistry on the wall, they would have figured this out. That's the problem with most doctors is they usually have like 2 years of chemistry. You know, they know how to write the equation, but they don't know how to solve it sometimes. And that's the reason we project forward. Some of the other ones are pretty smart, okay? But the guys that were doing this, no. They should have seen this one coming. After isoprene, isoprene is converted the next step to squalene. Where do we get squalene from? Shark cartilage. Shark cartilage is the fix for cancer. Sharks don't have cancer. Interesting programming, isn't it? What they didn't tell everybody is says, well, let's inject high amounts of squalene, let's eat tons of shark cartilage, and we'll fix cancer at this point in time. But you had a slight problem here. In our body, when we have a cell with a nuclei, it's the same with the cancer cell too, we supply the chemicals to the nuclei. The nuclei only does two things at that point in time. It makes proteins and squalene. It is the protector for cancer because it's usually a squalene reduction is what we usually measure in our patients. But the problem is eating shark cartilage, taking squalene injections, is the molecule is so large that we take in, it cannot be absorbed by the cells that needs it. But it's known that squalene, shark cartilage, is excellent for getting rid of skin carcinoma, surface carcinoma. What would be the difference here? Anytime you stick this guy into the system, the body only knows how to do one thing, reject, get rid of it. The term we use here is precipitate. So it either will pass it off into the urine, pass it off in the stool, or you will sweat it out. But take a look at skin carcinoma. We've got the skin. We got carcinoma on the top of it. We got all these nice, big, fat, healthy pores underneath it where we sweat. Much larger form of pore. Now the body has an excess of squalene from all the shark cartilage you've been eating and the parties you've been throwing with it. And the oil is being rejected. It fills up these little sweat glands right underneath the carcinoma. And this carcinoma over 3 weeks, 2 to 3 weeks, will flake up, dry up, and fall off. That's the reason it works. Because these pores are large enough to transmit the squalene. Now I answered your question, why did they do the isoprene and oxygen? Because they were looking for the chemicals to supply to the nuclei to make more squalene. That's the reason all the disciplines went to isoprenes for a while. Went to the benzenes, propanol compounds. Then the next thing happened is they found out this wasn't going to work with squalene. Squalene at that point makes one more transmission at this point. It goes to lanostrenol. Is the next conversion. And please, if you know the answer, y'all got a couple of y'all have heard this. Do you have any idea what the lanostrenol converts to at that point in time? It's an animal called C27, cholesterol. Heard good, bad, and ugly about cholesterol, right? Has anybody ever said anything good about cholesterol? Bad, 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 bad. Bad, 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 right? No, that's political stuff. Good and bad cholesterol. It's all bad. It's all bad. Let me ask a question. I know you guys are going to pop it. You really think is the ones I've seen, if you're my patients, I guarantee you'll never live to see tomorrow. Let the rest of these guys. Do you have any idea what cholesterol is used for?
Hormones, your brain, your nerves.
My God, somebody's been programming you with this. It's the fuel for the human growth hormone. Now you tell me what, human growth hormone is designed for the repair mechanisms in your body. If I shorten your cholesterol, I make it go dysfunctional. Cancer gets in the game. If I increase it, it goes dysfunctional. Cancer gets into the game. It's the fuel. I'm going to get you on this one. Cholesterol is the fuel for the human growth hormone that's inside us. It's what does the repair work on your tissue. But they would have you believe that cholesterol is all bad. But cholesterol is the fuel for your repair mechanisms. That's what goes on in the liver. That's exactly what it did. That's the reason I showed you the chemistry as it came out. Biggest problem is we have a lot of regulators out there on cholesterol right now. When we put cholesterol up at this point in time, 225, that is considered borderline at being a heart disease risk. Borderline, okay? And this is done in milligrams per deciliter, okay? But what they don't tell you about is a thing called triglycerides. These two guys work in unison. Triglyceride levels can move from 10 to 190, and it's considered normal. All right, we're going to try you. Where did you go, UT?
No.
I know that. Is how high can your cholesterol actually go and still be considered normal? Remember I told you 225 is an indicator.
About 330.
330? Well, you've probably been at 330, hadn't it? You lived.
What do you think 20 years is off the chart?
Oh, that's not true. We always have a chart. It goes from here to the space station, okay? We just extend the chart. It can go as high as 1,000 deciliters.
We've been told anything under 200 was supposed to be bad.
As long as the triglycerides remain normal. It means your body is processing and keeping it in balance. This is the main thing I'm looking for right here. Because you remember when I was showing you about the cells? Got a healthy cell, got an abnormal cell with a giant nuclei. My medication in general is furnishing the chemicals that are needed. But since these are healthy cells, the protein and squalene are able to pass back into the bloodstream. But the cancer cell keeps its squalene. Two things happen at this point in time. Patient for patient, and every one of my patients, triglycerides remain normal, but cholesterol moves up. That's where the patients ask me, how do I know it's working in me? Whoa. Well, I just punched up your squalene level, so we're feeding your human growth hormone to repair. Your triglycerides remain normal, means your body's dealing with it, you're repairing. Patient for patient, this has always happened in my patients. Because remember I told you about cancer, you can't test and measure this guy. You cannot pick him up in the lab, you got to physically see him. But two things happen, other than the squalene moving up, getting the fuel needed to your human growth hormone to help repair. You got to realize it's just not the cancer tissue that suffers here, it's the rest of your tissue suffers too. Because it's dysfunctional. It's not just one dysfunctional area in your body. In the process of this rising up, these guys, the healthy cells, are passing it with no problems. But these guys over here, different story. Remember I told you oxygen is always very low in areas. And then we have the discipline that high oxygen and cancer do not mix. But what everybody forgot is cancer has to have some oxygen. It's alive. It's very simple. It has to have some. Production that's going on here, our micron that actually forms inside the nuclei grabs the needed oxygen that the cancer needs. Other than constipating, we're taking away one of his tools to work with. Which weighs more, clean still or rusty still? Oh, y'all answer me. Clean still or rusty still?
Which weighs more?
Yeah, which weighs more? No, the rusty still, because it gained an oxygen molecule. Very minute in form, but it gained weight when it rusted. It added oxygen. And that's exactly what happens in this guy. Cells in general communicate. If it's nice, healthy cell tissue, they all connect, they all isolate at the same speed. They're in unison. It's like being in harmony type thing. But as we get into diseased tissue, we start seeing it separate where they do not touch, and they become erratic. This is one of the signals to tell the immune system it shouldn't be there. And in mine right here, I mean, you cannot measure it physically. I mean, you got to really have some good equipment here. But this cancer cell will gain approximately 8% in weight. But it's just enough to throw his oscillation cycle off. He slows down just a little bit. The moment he's not vibrating with normal tissue, bam, he's been tagged as being a bad guy, and now the body's got to go work on the immune system to figure out how to get rid of him. And that's the key, is to slow him down, feed him, constipate him, and gain some weight. And physically in my patients, you really don't see the tumors grow. But again, I always tell my patients, you know, it's expected to see anywhere from 3 maybe to 8% increase in a tumor. That's normal. It has to take the medicine in. It's that simple. If it doesn't expand, it means it didn't take the medicine. It's just simple physics. Everybody expects, well, I take this and the tumor's supposed to shrink immediately. No, you got to feed these guys. Just that simple. These guys eat. But at the same time, that's where we disrupt them. I try to explain to patients, you have to understand about cancer. Cancer not only has depth, width, I mean, it's incredible the dimensions these guys have. 2, they're located in places in your body where it's not designed to replace cell tissue all the time. So you have different cycle rates in patients in response to this type of medication. And what I'm seeing in general, and I have to use the breast cancer patients here, is we usually see a 2, 4, 6-month transition period in a patient once they've been treated. And it's because, 1, you don't know the depth of what the tumor is really dealing with here. 2, your chemistry unit is very unique, the way you absorb. I may be coming off someone that's back on that sodium garbage. Salt's bad for me. No, you need to eat some salt here. I got to get your cell transmission up again. And again, I mean, it's not a hard fixer. Put a sprinkle of salt on your food. That's all you got to do here. But I mean, I've got people that have phobias about salt. Well, I can't do that. My heart will do that. I said, look, cancer's going to kill you long before your heart gets you. And it finally sinks in. And next thing I know, they get just a little bit of salt. Didn't say eat it by the pound. But they get a little in there, and it's a major swing in the improvement in their lifestyle. And usually these 2, 4, 6 months has to do with cell replication rates. Remember I told you about the 27-day cycles? I go at the slowest rate. And usually if this tissue has been replaced, this tissue around about the 4th month comes online and starts functioning as normal tissue now. So you've got to get back in the cycle rates. You didn't suddenly wake up one morning and go, I've got a cardiovascular disease. I got cancer. It did not happen overnight. It took 15, 20, 30 years, 40 years. So don't expect the fix to be immediate. It's a gradual change. And along the way, the only thing I do is I try to fine-tune a few things in your life. And a lot of it here actually is the belief systems. I had one lady that was doing like 78 different medication and herbs and vitamins each day. Her entire meal, that was her meal. I went, what did you eat the rest of the day? All I know, she had the world's most expensive urine on this planet. No, I'm not going to tell that joke. Anyway, I promised I'd be nice today. But that's exactly what you were accomplishing here, because the body is like a glass of water when you take in chemical substances, vitamins. You can only put so much in before it runs over the edges. And when it runs over the edges in my cancer and cardiovascular patients, it's making your liver and kidneys and bladder and everything else work harder than is necessary. It's taking away, it's not adding to. That's the reason you need to know your minimum intake. Most of my patients, I've just put them on a basic multivitamin, mainly because I'm more worried about vitamin shortage than overload. And the key here is to know what works here. You know, you take your good multivitamin, but you have to know the mechanics of it. Is the vitamin a fix for you? Is it the only mechanism in you? No, you got to drink some water to get it down, one. But vitamins in general are useless without the fats. The fats are the transfer mechanism on most vitamins. So next thing one of my patients is going, well, doc, I'm taking flaxseed oil. I went, cool. That's 4 of the 28 fats you need to transfer the vitamins. So their entire life is on flaxseed oil. Yeah, okay. And then they wonder why they're not they're going dysfunctional here. And then we get on these fat-free diets and everything else. And usually this is a simple fix again. I'm the only doctor on the planet that prescribes 1 slice of pizza once a week. That's 1 slice, not the entire pizza. I've had problems with that one before too. And you don't buy the ones down here at the store because those are microwave jobs and they don't have all the fat you want. And plus it's nice to get out once a week and go get a pizza anyway. But that 1 slice, you make sure and get everything. All the cheeses, all the different meats. Anchovies are optional here. Okay? Okay, throw your garlic, onions, everything on it. But the odds are most pizza shops keep costs down is when they grease the pan, they use that old white lard like your mama used to use. And in that little guy is about 18 major components of fat. And it only takes a little bit, not a whole bunch. You don't eat this stuff by the handful. If you do, I want to take a picture of it. Okay, nobody will believe me. But there's just enough residual on that 1 slice of pizza to make all of these guys transfer correctly. And see, one without the other does not work. And that's where a lot of people say, well, I'm on a fat-free diet and I'm taking all the vitamins in the world and I can't figure out why I'm not getting better. Because you're not eating the fats you need. And again, flaxseed oil, that stuff is devastating because it's really shut down a lot of people's fat intake. And it takes a little bit. It doesn't take a bunch. Yeah, I'll tell one story. I had one patient I was working on. He's about 60 years old. Came in the clinic, I treated him, I did an exam for about an hour and a half on him, got pulled labs, everything back. Everything looked normal. He looked at me and says, doctor, is it okay for me to eat shrimp? And I went, do you have a problem with shrimp? He goes, no, but the other doctors told me not to eat it. And I said, well, I don't see any reactions. I don't see any reason why not. I said, yeah, you can eat shrimp. So he goes off to one of the local restaurants and he goes and gets him some shrimp. 7 o'clock the next morning, I'm called out of the OR and it's the manager of one of the restaurants. He goes, your patient's over here eating shrimp. I go, what's wrong with that? And he says, 7 o'clock in the morning. And I said, well, some people are strange. He says, doctor, he's eating his 8th plate of shrimp. So I sent the ambulance over, we hauled him back, we pumped his stomach out. And I know you guys, the doctor said it was okay to do. Yeah, That's exactly the way it works. So I say, use your common sense, okay? 7 plates, I didn't say 8. And that's the problem is we get so far left field on these things that we start missing the components. In the 50s, it was the 5 major groups, food groups is what was going to make us survive. In the 60s, 3 of those gave us cancer. In the 70s, 4 of them gave us cancer. In the 80s, all of them gave us cancer. I think back in the early 90s, 2 of them went back on the non-cancer list, and now they're all back on the cancer list again. And it's because research keeps bouncing back and forth. Okay, so anything you eat, everything you breathe will kill you, so quit that. Okay? Quit breathing, quit eating. Doctor's orders. I'll write that prescription for you. And if you last more than 10 minutes holding your breath, I'll get it on the cam. We'll get something out of it. I've been telling people about toxins, and I'd like to use an example of a recent case. I mean, beautiful young lady. Not going to name any names here. She works as an aircraft mechanic, but she's a classical that I'm starting to see in patients. It's incredible about the beautiful women I work with. Notice I didn't say old, okay? The problem is the more progressive the disease becomes on women in general, it's interesting, is women put a higher priority on looking beautiful for their husbands than they do recovering from a disease. I'm one of the few people on this planet that will make that comment. There's nothing wrong with being beautiful and caring about your husband. But the problem is they start putting on more makeup as they get sicker to try to make up, especially if you're coming out of a chemo regimen. And what I'm noticing is I'm noticing thicker and thicker layers of fingernail polish. Okay? I looked in the National Chemical Index here stateside trying to find out about carcinogenic effects of acetone in fingernail polish. And what was incredible what I got back is I got back an incredible report of 1 page with 2 sentences. No carcinogenic studies have ever been done on acetone. And yet it's in everything we touch. All I know is you stick your hand in acetone, pull it out, let it dry, stick your hand in, pull it out again, or somewhere around that the skin starts flaking off your hand. Fits all the things called an abrasive on my body that eventually will cause cancer if I keep doing it long enough. So I advise the women not to quit using fingernail polish, but try to find alternatives, to try, or at least find ones that have a lower content of acetone in them. Because I see tumors flare in my patients. I've also seen tumors flare in my patients with thyroid cancer that are exposed to pesticides. California taught me that because they spray flowers out there for the people to enjoy the flowers later in the day. My cancer patients were going out 30 minutes after they sprayed, breathing this stuff. Next thing I know, their thyroid cancer had flared tremendously. The moment we moved them from Monday to Tuesday, when they didn't spray, the tumor went back to normal. And you got to be aware of those things. But acetone has got to be one of the most devastating. This lady came off 6 years in the military working on jet engines, doing the same thing. And then the last year she spent 3 years with acetone cleaning the turbines on engines. With and without gloves. Doesn't really make any difference. But she had so much exposure to this stuff. I think she's going to respond because we do know the mechanics. One, we're getting all the safety equipment back on her again. We've gotten medication in place, and so now we're in the race of time. But the most unique thing you have to understand is, you remember I told you about the processing of this guy right here? Do any of y'all have any idea why you get drunk when you drink alcohol? Yeah. The interesting thing is when alcohol hits the stomach, it's converted to acetone, and that's pushed off into the bloodstream. Acetone is very foreign to our body, and what happens is the body gives up oxygen into the bloodstream to try to get rid of the acetone. And in the process of the oxygen it gives up, that depleted oxygen blood that hits our brain is what makes us drunk. Not the chemical, it's the lack of oxygen. But that's how the body reacts against acetone. And then when you're putting it on your fingernails and it's coming right through your quicks, it's almost like putting it straight into your bloodstream. And when we deal with breakdowns in alcohols, I don't know if I would do this one, it's probably a little too complicated, is we deal in what we call three layers of ketones. These are called ketones. We have a primary, a secondary, and what's called a tertiary form. Acetone comes in on the tertiary form to a certain degree. But in general, what happens in most alcohol conversions, and this has to specifically do with drinking alcohol, I don't really have too much problem with that because usually moderation and common sense, or you just pass out before you drink too much, usually takes care of you. But rubbing alcohol we do have a problem with because it's a different mechanism that goes into you. And what most people don't realize is all these start on the front end with benzene. Yeah, it's interesting what benzene is. But after you get through with benzene, going through a primary, secondary, that's what you end up with. In the chemical structures, it's a little bit more complicated than that. But basically all it comes back to is benzene poisoning, which is very hard for us to get out of our body. And if you look into a lot of the hair products and stuff that we use and everything, it always has a benzyl radical of some kind. They're very devastating. They're very hard to get out of our systems once they're absorbed. In pharmaceutical industry, benzenes is what we use for accelerators in pharmaceuticals. Some medications make you feel better, accelerate you, boost you. Okay? I mean, this is the way the chemistry breaks down. In toluene, specifically O, is the ones that slow you down. This is where they come from. They're built from these base compounds here. So when you're looking at chemicals in general, if you understand, if you're starting to get an excited condition over something, suspect benzene, because your body's processing benzene into an accelerator. If you're slowing down, expect a toluene intrusion in your life. And this is the way we do it in pharmaceuticals. This is what I try to teach my patients when they dig and look. Propylene compounds, anything with propyl in front of it, and believe me, they're really good at the way they cloak these in substances right now. All of a sudden, alcohol is called propyl. Well, that's one of its secondary forms. It's still alcohol. Still basically rubbing alcohol is what I'm after here. So you be careful with your propyls. Propyls, again, related back to benzene. I mean, y'all remember this big benzene scare they had in the drinking water back, and they had to call all these bottles back and everything? What do you think the benzene was still in there? Did it just come off the side of the bottle? Well, you understand the way plastic is a liquid. But see, the way we make plastic is we expose it to X-ray. You hit it with X-ray, it stiffens up. More X-ray, stiffer it becomes. So guess what happens when you take your bottle of water and stick it out in the sunlight? It's still curing, and to cure, it's giving off benzene into your water. Now, why does that water have that plastic taste, Ethel? We've all done it, haven't we? We didn't say Ethel. But I'd like you to know where that plastic taste comes from. And I'd like you to know how hard your body fights to get rid of that benzene. So you didn't ask for this. But that's one of the smaller toxic poisons we take in that's very devastating. Back to my nice young lady with the aircraft. Her acetone intake is so high. Now remember I told you when the body's trying to get rid of something, it usually precipitates it. It tries to get it out through the urine, tries to get it out through the sweat pores, it tries to get it out through the blood. Her intake is so high that the liver basically, and the best way I can put it is it's forming lesions on the outside of the liver. But that's not a correct term here. It means the liver is trying to process it so fast that actually you're getting crystallized form of acetone on the outside of the liver, which is being interpreted as a lesion. Now you tell me how the body rejects stuff. And yet it's a crystalline form, it's so stable, I don't know if the body's going to be able to dissolve it in the long run or if it has to be removed surgically. But if you're a good cancer specialist, well, hey, let's just give her chemo and radiate the hell out of her because it's a lesion, it's not a crystal. But it's just like you're seeing crystals that form when they're coming out of a chemical reaction. And they're forming on the outside because they haven't got another way to exit from the body. Heavy metal poisoning. I love that term, okay? This is what chelation therapy was originally designed for. But it was designed for copper poisoning. That's not a heavy metal, okay? Don't weigh that much. Eventually, it was originally designed, back in the 1950s, it was designed for lead poisoning. Then around about 55, they found out it was actually good for copper poisoning too. But again, it was only designed to be used once in the emergency OR to buy you time so you could recover. It was not designed for you to go through 40 times. And then somewhere up and down the pike, someone went, ooh, copper, lead, ooh, heavy metal. So now it's good for all heavy metal poisoning. No, it's not. I mean, copper and lead, yeah. Mercury poisoning out there is a different thing. Mercury poisoning is not the physical metal that we ingest. It's the mercury oxide. It's what comes off the mercury is what's devastating to us. The vapor. The problem is this guy is where it collects the residual from those vapors when it oxidizes in our system. Having basically your mercury fillings pulled does not accomplish this because that's a pretty stable metal already in your mouth. There's big arguments on this one, but last time I checked, those guys are pretty stable and they're not giving off oxides. If it's still in question, remove them. It's just that simple. It's not that big of a decision to make. But the problem is when you're exposed to this, Remember back when you were little and first time you had a nickel and some mercury and you started polishing it, make it shiny? Well, all I know is, and whether you did this or not, in the 7th grade, they made us do it in science class. Ooh, look and see how it adheres. The problem is what you were breathing at that point in time. And the problem is in mercury, mercury isn't accumulative. If it takes 10 parts of mercury to kill you, and you were in the 7th grade and you took 9 parts at that point in time, I don't care if you're 75 years, all it's going to take is 1 more part to kill you. That's how well it adheres to your system. In all the chelation therapies, all the fancy herbal substances, all the fancy pharmaceuticals that we have out there, what do you think is the one substance on this planet that can actually physically remove mercury from your system and be measured? White bread. It's the only thing. White bread. And it's like my patients. I have them eat 2 slices a week. That's it. 2. And the reason you can measure it is because what happens is when you chew it up and swallow it, I don't know, hot dogs are optional here, it forms a little ball of gluten in your stomach. Glue. That's exactly what it is. And it rolls down your intestines. It goes down this way. Then it jumps over here. And in the process, guess what? Sticks to it. And you can measure it coming out the way the British put it, when it drops out. I love the way the